Hello, I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure today of moderating our tumor board. And I'm going to ask our esteemed panelists if they wouldn't mind going ahead and introducing themselves. We'll start out with Dr. O'Shaughnessy.
Hi everyone. Joyce O'Shaughnessy. I'm in Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas, and I'm a breast medical oncologist. Very nice to be here with you today.
I am Dr. Frank Piccini, radiation oncologist with Genesis Care in Michigan.
Hi, I'm Norman Woolmark. I'm professor of surgery at the University of Pittsburgh. I'm chairman of the NSABP Foundation and co-principal PI of NRG Oncology.
I'm Maxine Jockelson, and I am a professor of radiology at Memorial Sloan Kettering Cancer Center, where I direct the imaging for the Breast and Imaging Center. I'm primarily a breast imager with a little sideshow of doing PET scanning as well.
Is a 64-year-old African-American female with an ECOG performance status of 2, a history of ER/PR positive, HER2-negative left invasive ductal carcinoma, now with metastatic disease to the bone, liver, brain, and diffuse lymphatic lymph node involvement. She has failed multiple systemic therapies, including endocrine therapies with fulvestrant, palbociclib, and letrozole, everolimus and exemestane, capecitabine, vinorelbine, doxorubicin, and docetaxel, as well as radiation therapy, and now with recent extraaxial mass with completion of whole brain radiation therapy and progression of her disease with left supraclavicular mass, as well as left axillary and internal mammary, as well as mediastinal lymphadenopathy. So the question being raised is which systemic therapy would be recommended next, and would palliative radiation to her left supraclavicular mass for pain control be recommended despite the lack of previous radiation dosing in history? So those records are not available. And we have a little bit of imaging here, if Dr. Jockelson can comment for us.
Sure. So we have multiple views, primarily of the left supraclavicular region, which I think also includes the brachial plexus as well with these images. They're just small slices in each view, but certainly she has a very large infiltrating mass, and it looks from the one view that part of it may be infiltrating one of her vertebral bodies as well. Again, it's hard to get a good picture, but certainly the placement of this and the extensiveness of this, I can certainly see where it might be causing her pain, and also at some point potentially neurologic deficits. So it's a fairly extensive amount of disease in that region.
Perfect. Dr. Piccini, do you want to comment about the role of radiation therapy here and how comfortable you would feel doing that in terms of the safety of the supraclav area, given that the previous radiation records aren't able to be obtained?
Yes, a not uncommon problem we have. So she would probably be a candidate for stereotactic radiosurgery to that area, given the higher risk of causing potential toxicity. I mean, I think the response rate with the fractionation schemes that we're using now and the techniques could be as high as 80%. So I think it does justify the risk to go ahead and give her anywhere from 3 to 5 stereotactic fractions of radiation therapy with a potentially good response rate. Even though you don't know the doses or the timing, which of course we would try to do, but unfortunately that happens quite a bit.
Perfect. Thank you for that. And Dr. O'Shaughnessy, just to pull back up for you the list of previous therapies that this patient has had, she still has a reasonably good performance status, I guess, with a performance status of 2, assuming that she wants additional systemic therapy. What would be your preference?
So I would like to have another biopsy of a relatively recent development of metastasis, whether it be the supraclav or whether it be a new liver metastasis, because a lot can change over the course of this natural history, right? So you really want to look again at that estrogen receptor, because that's going to make a big difference. The HER2 can absolutely change. You'd love to get enough tissue for good comprehensive NGS. There's a lot of targets here that would make a big difference in what you might think about, from PIK3CA to HER2 to somatic BRCA to NTRK to PIK3CA, a bunch. and also circulating tumor DNA, because they're not completely concordant. So you can get information, and particularly when patients are progressing, that's a perfect time to do ctDNA. So things can certainly change. You can get clonal outgrowth, but she needs cytoreduction. This is very bad pain when you have that brachial plexus pain. She needs cytoreduction. So even not knowing those things we would like to know, eribulin, for example, is quite non-cross resistant, and you can get very, very nice cytoreduction. If she were found to be ER negative at this time, Sacituzumab is really good for this socked in local regional stuff with the triple negative patients. I have a number of African-American women who suffer with this. They come back in a local regional in spite of, ideal surgery and radiation therapy. And Sacituzumab provides a lot of excellent palliation. Work with the radiation doc, see if we can get something down for them first and before they come in with their radiation therapy. If she still had some ER, some convincing level of ER with a biology that wasn't terribly highly proliferative, because I don't think the CDK4/6 inhibitors, if you're really dealing with a basal-like type ER positive, I don't think they work. In fact, I think they can accelerate disease. But if we really do see there's a decent level of ER and, there's the Ki-67 still in the luminal ballpark, even bringing in abemaciclib, would be an option for her. But I would really, she hasn't had a platinum-based regimen either. So if she had a really high Ki-67 and you thought you're dealing more with a basal-like or HRD type biology, you could bring in a platinum-based regimen. But eribulin would probably be a very good standard of care in terms of just the level 1 evidence to get her some good cytoreduction, at this time.
Perfect.
Yeah, Joyce brings up a great point. Obviously, first we would wait to see whether or not she had something to offer this patient to do cytoreduction, and then we would come in with the radiation therapy. But sometimes it's always that risk. Will it respond to the systemic therapy? She will come in with the radiation. So this is where we work with the medical oncologist hand in hand to make the determination what comes next.
Perfect. So in summary, we'd recommend careful multidisciplinary consultation with radiation oncology and medical oncology to determine order of treatment here, but definitely consider a biopsy of the recent metastatic disease, whether that's the supraclavicular disease with confirmation of the ER and HER2 status. We'd like to also obtain enough tissue for next generation sequencing and obtaining circulating tumor DNA. Really consider something like eribulin or Sacituzumab, govitecan, if it looks like it tends to be more of a basal-like phenotype. Also consideration of a platinum-based regimen if there is a high proliferative index, and certainly consider stereotactic radiosurgery in 3 to 5 fractions for palliation.